Welcome back, everyone, to the third session of the NDF, which will be on Alzheimer's disease. Our first presentation will be the Biogen Symposium, and our speaker will be Tawfiq El-Saadi. Now, he has another commitment afterwards, so he'd like to do his question and answering session immediately after his talk. So if you have any questions, if you post them during his presentation. So as I say, it's a pleasure to introduce to Dr. Tawfiq. He's currently in the American Center for Psychiatry and Neurology. He trained in epilepsy and clinical neurophysiology in the University of California in San Francisco, where he's an epilepsy fellow there, and he's board certified in the United States. He, when he was at UAE, previously he was the chief of neurology at Sheikh Khalifa Medical City in Abu Dhabi for 11 years. And now he's moved on. He's a chief medical officer and the chair of the neurology department at the American Center for Psychiatry and Neurology in Abu Dhabi. He's been honored with several prestigious awards for his work in epilepsy. And he's currently the president of the Emirati League Against Epilepsy. And he also serves in the editorial board for BMC Journal of Neurology and Journal of Neurosciences. He himself has published on numerous occasions and numerous publications to his name, both on epilepsy and neurology in the UAE. So it's my pleasure to introduce Dr. Tawfiq.
Thank you very much, Dr. Ajith, for the kind introduction. I'd like to thank Biogen for sponsoring this symposium. Let me see if I can share my slides. Let me see, how can I get to the button to share slides here? Give me a second here. I think I'll get there. Yeah, I got it. Do you see the screen now?
Yes, we do. If you can make it on full view, that's thank you.
It is. Can you see now the full screen?
Yes, doctor. You can proceed.
Yeah. Okay, very good. So obviously we're practicing at a very exciting era now. Finally, we have some hope for patients with Alzheimer's disease. Previously, the way that we used to treat Alzheimer's disease was based on some symptomatic treatment, but finally now we're trying to get to the bottom of the disease and trying to understand way better the ways that we can manage these patients with Alzheimer's disease. And this is going to be the scope of the new molecule that I'm sure you're all familiar with, that had been recently approved by the FDA for that indication. So we'll discuss with you some of the pivotal trials that had resulted in the approval by the FDA for aducanumab in patients with Alzheimer's disease. And I'll start off with the first trial, which is a PRIME trial, which is a phase 1 class 2 evidence trial. The reason it was class 2 because 80% or less than 80% of the study population had completed the trials. It included patients with prodromal or mild Alzheimer's disease who had MMSE of more than 20 with a stable concomitant medications, but with a positive amyloid PET scan. The trial was a double-blinded placebo-controlled trials where patients were randomized to either 1, 3, 6, or 10 milligram per kilogram of the medication as compared to placebo. And the patients were stratified according to the ApoE4 status. The primary endpoint of the trial was basically safety and tolerability of aducanumab, whereas the secondary endpoint was the serum PK as well as the change in amyloid PET that was measured at week 26. The trials, again, was not powered enough to detect any clinical meaningful information, so the information on a clinical aspect of the trial was mostly based on exploratory endpoints, which is a change in the clinical dementia scales, as well as MMSE, as well as other measures at week 54. So if you look at here, the slide, the inclusion criteria, again, it had included patients who had met the criteria for prodromal or mild Alzheimer's disease, who had visually positive amyloid pathology, consent to ApoE genotyping, as well as they are in good health, meaning that they excluded patients who had uncontrolled medical or neurological condition that might be a contributing cause of patients' cognitive impairment. They've also included patients with a stroke and TIA, as well as if patient had MRI showing evidence of brain hemorrhage or cortical or subcortical infarct, clinically significant psychiatric illness in the preceding 6 months, history of significant cardiac disorder within 1 year of screening, patients with systemic illness or infection in the past 30 days, including patients with HIV infection, patients with impaired renal or hepatic function, as well as those patients with poorly controlled diabetes, and if there's any contraindication to brain imaging or PET scan. Again, as you can see, they included patients with prodromal Alzheimer's disease or mild AD, and patient had been followed up to 1 year of the trial. This is a double-blinded placebo-controlled trial where patients had been randomized to either 1 or 3 milligram as compared to placebo, 6 milligram as compared to placebo, or 10 milligram as compared to placebo. Patients who have completed the double-blinded phase of the trial, they ended up in the long-term extension phase up to 1 year of after they completed the double-blinded phase of the trial. This is the titration dosing regimen, as I mentioned, double-blinded placebo-controlled trial, 1:3 versus placebo, 6 against placebo, or 10 against placebo, and then the long-term extension phase of the trial. Patients had received infusion every 4 weeks over 52 weeks of the treatment trial, and then when they went into the long-term extension, they received also IV infusion every 4 weeks up to 6 years of the completing the double-blinded phase of the trial with the scheduled MRI follow-ups, as well as amyloid PET and clinical testing. This is the patient's demographics, as you can see in this slide here. The mean age around 72. There were 2/3 patients were female, and about 2/3 of these patients were carrier of the ApoE4. About half of the cohort had prodromal phase of Alzheimer's disease, another half had mild AD, and you can see the average score on MMSE as well as the global scale of dementia scale, as you can see in the cohorts. But most of these patients had a score of 0.5, less than 15% had a score of 15 or less. Now, if you look, as I said, the primary endpoint of the trial was safety and tolerability. By month 12, the most common adverse effect with the trial was ARIA, which is the imaging abnormalities as related to medication, which typically resolve within 4 to 12 weeks of the trial. And the other common adverse effects, which had happened in more than 15% in the patient-treated group, included headache, urinary tract infection, as well as respiratory tract infection, diarrhea, as well as arthralgia. But as you can see from this slide, what you can easily appreciate that the ARIA has mostly detected in a dose-dependent manner, meaning that the higher the dose, the more likely you would encounter ARIA E. And it is also more significantly encountered on those patients who are positive for ApoE4 carrier. So it's a dose-dependent and more encountered in those patients, as you can see in the green bar here, those who are positive for ApoE4 carrier. The secondary endpoint of the trial, as I mentioned, were exploratory because it was not powered enough to detect any clinical meaningful information. But as you can see here, that if you look as compared to the baseline, there's a significant drop in the measurements or the uptake of the amyloid in a dose-dependent manner in patients who are treated with aducanumab as compared to the placebo, and that was more significantly encountered in those patients who are randomized to the highest dose group, meaning 10 milligram per kilogram. So there's a dose-dependent reduction in the amyloid uptake in a dose-dependent and time manner in the treatment group as compared to the placebo arm. Now, does it translate into clinical encounter? As I mentioned, the design of the trial was not powered enough to detect any meaningful clinical encounter. But if you look at an exploratory manner, if you look at the end of the 54 weeks of the trial, there was a statistically significant reduction in the global dementia scale in patients who were randomized to the high-dose treatment arm of 10 milligram per kilogram as compared with the placebo arm. Now, if you look at another way of measuring the clinical outcome using MMSE, there's again significant reduction at week 52 in those patients who were randomized to the highest dose arm, 10 milligram per kilogram, as compared to the placebo arm, in addition to those patients who were randomized to 3 milligram per kilogram as compared to the placebo arm in the trial. So the takeaway message from that PRIME trial, that in the 12 months interim analysis of the phase 1b PRIME study, the drug had reduced the beta amyloid plaques in a dose and time-dependent fashion in patients with prodromal, as well as for those with mild Alzheimer's disease. In the 12 months interim analysis of the trial, the drug had shown clinical decline as measured by the global dementia scale, as well as those patients who had utilized the MMSE scores in patients with, again, prodromal or mild Alzheimer's disease. And the area E were mainly the main safety and tolerability finding in the trial, but again, emphasizing that it is highly encountered in patients who are in the highest dose, and especially for those who are positive for the ApoE4 carrier. But most of the patients had the area E would resolve after several weeks of the treatment, and most of the area E had occurred early in the course of the treatment, usually in the first 3 to 4 months of the treatment. Now, what about the other two pivotal phase 3 trials, EMERGE and ENGAGE trials? Both of these trials had followed an identical protocol. They both are double-blinded, placebo-controlled trials, 18 months duration, class 2 evidence, again, because they had less than 80% of the patient had completed the trial. It's a multi-international studies where more than 3,000 patients had been enrolled over 340 sites in 20 some countries. They also included patients with early Alzheimer's disease, including those patients with MCI Alzheimer type, as well as mild Alzheimer's disease. It's a double-blinded placebo-controlled trial where patients are randomized to either a small dose as compared to high dose, and the dosing regimen had followed according to the stratification of the ApoE4 carrier state. Included patients with the age 50 up to 85, the diagnosed with early Alzheimer's disease, MCI Alzheimer type are included, and again, similar to what we have seen with the PRIME trial, positive amyloid PET scan. They also included patients with uncontrolled medical as well as neurological condition, systemic illness, serious infection, or other relevant medical conditions, and or had participated in any other immunotherapy study targeting A-beta within the previous 12 months of the screening. Again, if you look at the trial, that included patients with early Alzheimer's disease with a score of MSE between 24 and 30, or the global dementia scale of 0.5 with visually positive amyloid PET scans. And it's a placebo-controlled trial, so patients randomized either placebo or low dose of the medication. Again, depending on the ApoE4 carrier state, in patients who are positive carrier state, they're randomized to 3 milligram per kilogram, whereas for patients who are not carrier, they randomized to 6 milligram per kilogram, or the high dose, 6 milligram per kilogram for the high dose in patients who are positive for ApoE versus 10 milligram in patients who are non-carrier of the ApoE4. But then eventually all the patients had ended in the 10 milligram per kilogram in the study protocol version 4, which is the modified protocol. The endpoint of the trial was the primary endpoint with the clinical dementia scale. The secondary endpoints were the MSC as well as the ADA score, as well as the amyloid PET studies. The clinical dementia scale is a measurement of cognitive and functional component of the scale. This is how the study or the scale is measured using filling out this questionnaire. The secondary output of the trial, again, had measured the MSE as well as the ADAS-Cog3, as well as the PET measurement or uptake. This is the schedule of the design. Patients had received infusion every 4 weeks over 76 weeks after a screening phase that can last up to 60 days. And this is the duration of the placebo-controlled arm. Patients obviously after had completed the double-blinded phase of the trial, they ended into the long-term extension phase of the trial with the specified MRI measurements as well as the amyloid PET scans according to the scheme of the trial, as well as obviously clinical testing. Again, as I mentioned, that patients are randomized to low dose versus high dose, and the dose has been stratified according to the ApoE4 carrier status. So in patients who are positive, they randomized to 3 milligram as compared to non-carriers, the low dose 6 milligram per kilogram. For patients on the high dose, randomized to 6 milligram per kilogram in the ApoE4 carrier as compared to 10 milligram in the non-carriers. But eventually all patients had ended up in the 10 milligram per kilogram according to the revised protocol, which is protocol version 4. Now, this is the duration of the trial. Obviously, the futility had met after almost half of the patients had been included because of the development of the area and the trial, and had resulted to unblind the trial, and the futility had been met almost halfway through of the inclusion of the trial. Now, the eMERGE, obviously, if you look at the results of the trial, the eMERGE study had met its primary endpoint as the pre-specified statistical analysis plan, showing a statistically significant reduction in a clinical decline as compared to placebo, and we'll show that later on, where, however, with the ENGAGE trial, did not meet its primary endpoint, however, with a subset analysis of the group or the cohorts of patients who had received the higher dose of 10 milligram per kilogram. In that group, there was statistically significant improvement in the clinical outcome only in that subset of the population in the ENGAGE trial. So, as I mentioned earlier, that all of these patients had ended up on the higher dose of the medication, which is the 10 milligram per kilogram, as per the modified protocol, and that could explain the differences in the outcome of both of these trials. This is the outline, as I mentioned earlier, how the dosage was stratified according to the either low dose or high dose based on the ApoE4 carrier status. And this is the median cumulative dose at week 78, as I mentioned, in the low dose as compared to the high dose of the arm of the trial. Now, if you look at the study results, this is the demographics in the two trials, the average age similar to what we have seen in the PRIME trial in the 70s. About 50% of the patients were female, another 50% were obviously male. But if you can see in the race, most of the patients that enrolled on the study had been in the white population, and that some of the critiques of the study that it did not include other minorities, Blacks as well as Asians and others. So most of the study population were whites. If you look at the ApoE4 status, about 2/3 were carriers and about 1/3 were non-carriers. If you look at the characteristics of both groups, this is the eMERGE as well as the ENGAGE, and the average score on the MMSE, which was almost in the 26 range in both of these two trials. And the global dementia rating scale, most of their cohorts had been at the 0.5 scale, and less than 1% were scored 1 on that scale. If you look at the primary endpoint, as I mentioned before, it had been met in the eMERGE trial, but not so much in the ENGAGE trial. But again, looking at the analysis of the cohort of patients who were randomized to the high dose of 10 milligram per kilogram, the study endpoint had been met in that category only, the patients who had randomized to the highest dose arm of the trial. If you look at the in a graphs manner. Obviously, there's statistically significant reduction in the clinical dementia rating scale in patients in the emerge trial, not so much in the engage trial, except, as I mentioned, in the sub-cohort of patients who are randomized to the high dose, but that doesn't show in that graph. And if you look at the uptake of the amyloid beta, that also has been statistically significant in patients who are randomized to the high dose in the engage trial, less so in the patients with the emerge trial, not less so in patients with the engage trial. Now, what about the safety results? About 40% of patients had discontinued treatment, either because of adverse effects or because they withdrawn the study due to either consent had withdrawn or other reasons. They did not continue on the trial. But most of the adverse effects were mild ones. The serious adverse effect had been reported in less than 15% of their patients, and mostly were related to the occurrence of ARIA, which had been reported in less than 10% of the patients in both of the trials, emerge as well as in the engage trial. But if you look at the percentage of patients who had discontinued treatment due to ARIA, was obviously very small. Less than 5% of patients would discontinue treatment due to the occurrence of ARIA. With the reported death, there's only one reported death in the trial. We're all familiar with ARIA by now, which is the amyloid-related imaging abnormalities, which is not new, actually. As a matter of fact, is being reported before, which is thought to represent vasogenic edema as well as cerebral microhemorrhage, was reported first back in 2009, the initial clinical trials with papineuzumab, and since has been associated with other investigational drugs that had target the amyloid beta. We know there are two types of ARIA E, which is a parenchymal edema, and ARIA H, which hemocysteine deposition, or that can be detected by the gradient T echo. Obviously, both of these ARIA E as well as ARIA H may be caused by the clearance of E beta from the cerebral vessels. And this is how we can detect ARIA E and ARIA H. ARIA E is best detected by FAIR sequences, whereas with the ARIA H by the gradient is T2 echo. And the way that you can follow these changes. Most of the adverse effect, as I mentioned, that related to ARIA had occurred in a dose-dependent manner, meaning the highest dose, the more likely you would encounter ARIA, especially ARIA H. And also similar to what we have seen with the prime studies, it is more encountered in patients who are positive on ApoE4 carrier as compared to patients who are non-carrier. And you can see here that the percent of patients that discontinued treatment due to the ARIA H is quite small. This is, if you look at the percent of patients has symptomatic symptoms related to ARIA, is very small, probably less than 10%, and most of the patients were asymptomatic, and most of the symptoms that had been encountered with ARIA were related to headaches, as well as dizziness, visual obscuration, nausea, and vomiting. But most of the ARIA symptoms would resolve within 4 to 16 weeks of a treatment. So, and if you look at the summary of the two of the phase 3 pivotal trials, the emerge high-dose aducanumab had resulted in a clinical decline as measured by primary and secondary endpoints. In the engage trial, the aducanumab did not reduce clinical decline, but in the sub-analysis, the drug showed an effect on amyloid PET, and the most common adverse effect were ARIA E and headaches. This is how the drug is indicated by the FDA. Obviously, the FDA had suggested to use it in patients with early Alzheimer's disease or MCI Alzheimer type, and obviously suggesting to obtain MRI within 1 year prior to initiation of the treatment. And we're all familiar with the precautionary measures that follows the protocol to initiate this medication. With that, I believe I end, and I'll be happy to take any questions if you have any questions about this presentation. Thank you very much.
Thank you, Tawfiq. I'm just looking at the questions. None appeared so far. As you know, the initial approval was thought to be somewhat controversial because it got an accelerated approval. Where do we stand now as regards to treatment? Because I think the insurance companies in the United States have set various restrictions on use.
Well, you know very well that this drug had created so much controversy, and there's still so much people had basically questioning the way that drug was approved by the FDA in the first place. And there's so much limitations to the way using this medication because, again, it included patients with a specific diagnosis with Alzheimer's disease, mostly those with early Alzheimer's disease, with visually positive amyloid on PET studies. As I mentioned earlier, it excluded patients with other types of Alzheimer's disease, also excluded patients who are, if we call it the minorities, including Blacks, Hispanics, etc. So we don't know what's going to be the case in patients with that group. It had also excluded patients with other systemic and neurological disorders. And indeed, if you look at the Medicare, with a recent analysis on this, they looked at their cohort of patients who could be a candidate for this medication. It turns out that less than 5% of their patients with Alzheimer's disease would be candidate based on the criteria that had been set forth by the study design. So less than 5% of patients who could have been eligible to receive this medication would receive this medication based on the strict criteria and the protocol that had been set forth for this medication.
Thank you. We've got a question from Ahmed Allah. Is it effective against all dementia, vascular dementia, and is this the future treatment pathway?
We don't know. Again, it's only had been developed for patients with Alzheimer's disease dementia and MCI, Alzheimer type, or early dementia. So we don't know. And that's, again, the difficulty with this medication, that it's only included a subset of patients with dementia, specifically those with Alzheimer type dementia. So we don't know if it will work on vascular dementia. I would believe not, but this is too early because I believe the way that this drug works may not apply for patients with other type of dementia other than Alzheimer type dementia.
Yeah, I think it's worth noting it's a monoclonal antibody and it's clearing amyloid. So the other dementias aren't necessarily related to amyloid. So
absolutely.
It's very targeted therapy. Now, as regards its role here, have you had any experience in trying to give the drug here at all?
We did not, because again, the issue here, obviously you have to screen for these patients. You have to screen for patients with early dementia. And as you know, one of the main difficulties we face with the dementia community, that most patients that come to our attention probably later in the course of the dementic illness. So you need to start screening for patients with early dementia in order to see if they could be a candidate for this medication. Again, it can only be offered for patients with early dementia who have visually positive amyloid based on PET studies as well as on CSF. So it's going to be very highly selected group of patients that could be candidate for this medication. But certainly it is a start.
Yeah. I think as regards to the PET scanning, it's one of the reasons I've got this afternoon session 4 on neuroimaging, because since I moved to Burjeel Medical City, I've tried to set up a dementia clinic, and particularly, as you say, we need to pick these patients up early, so it needs to be good screening. And then the next step is going to be, if you're going to try and use these agents, is to demonstrate amyloid on PET. So we've had some progress in that. I had a high-level meeting with Daman, and they've agreed to the use of PET, including in Daman basic patients. And now it's a question, at the moment it's FDG PET, but we're trying to get the ligands to show amyloid and also tau. So hopefully we'll be in a position, and Dr. Tamer will be our last speaker. He'll be talking about the progress we've made on, that to date. At the moment, we don't have the tau, and we don't really have a good amyloid, but it's on its way, hopefully. So we can offer that service to anyone, hopefully.
Well, if that works, then obviously that could open up a golden opportunity. Yeah, absolutely.
Because I think, in this country, it's sort of thought that people get elderly and they lose their memory. I think and there's a good family structure to look after these patients. If we can try and pick them up early, and it's a big push now to do that with disease-modifying therapies like you've just discussed. This is the first step, really. So now we have to really start mobilizing clinics to try and get these patients early. But thank you very much. It's a very, very good overview on the medication, and particularly, with where we are at the moment. And I think in this regard, the Emerge and Engage, there's another trial going on now called Embark, which hopefully will get some results next year. These just because of the initial controversy with the FDA. So there's an ongoing studies in this. So hopefully, these kind of medications will be around.
We'll have better answers. Absolutely.
Yeah, absolutely. Thank you very much.
Thank you much. Thank you. Thank you. Bye.
Bye. So I can't see any more questions for now. So I think that was the last question. It was about vascular and other treatment pathways. So I'll proceed with my talks. It's very good timing by Dr. Tufik. Finished at 2:45. So I've got half an hour, and I'll just share my screen. Can you see that?
Yes.
Good. So this presentation is going to be on the updates in the management of Alzheimer's dementia. So I've only got half an hour to speak, so it's going to be a very high level view looking at various aspects of managing Alzheimer's. And these are my conflicts of interest. And the learning objectives is to get an overview of cognitive disorders, so appreciate there's a spectrum of disease, which Dr. Tufik already alluded to. Appreciate the importance of early detection, understanding current and upcoming methods of early detection, and get an update on current medications available for Alzheimer's. So dementia is a syndrome. It's not a specific diagnosis per se. It's an umbrella term used to describe a range of symptoms associated with cognitive impairment. Alzheimer's is by far the commonest, accounts for 60 to 80%, vascular dementia 10 to 40%, Lewy body disease to 20 to 25%, and frontotemporal dementia 10%. But it's worthwhile appreciating that a lot of patients have a mixture of these. So often you get Alzheimer's disease mixed with vascular dementia and Lewy body disease with vascular dementia. So you never get the pure disease as such, which is why Dr. Tufik was saying only about 5% of an overall population may be able to fit into these specific trials on Alzheimer's disease. And this is the spectrum of disease from cognitively unimpaired to mild cognitive impairment to mild to moderate to severe dementia going towards the right. And you can appreciate with any disease modifying therapy, the earlier you can get the treatment in, the more likely it's going to be effective. There's no point really starting disease modifying therapies at the right end of the spectrum when we've already lost a lot of neurons. And mild cognitive impairment, the definition is an impairment that does not interfere with activities of daily living, whereas dementia is when the cognitive impairment starts to interfere with activities of daily living. And there's about a 10 to 15% annual rate of conversion from MCI, mild cognitive impairment, to the dementias. And now, this is why it's very important to get early detection and diagnosis. When we had no disease-modifying therapies, it didn't really matter that much. But now we're in the era of potential disease-modifying therapies. So the quicker we can detect disease, the better. And I'll be looking at three aspects of biomarkers that are really changing the game. There's brain imaging, which we'll go into more detail in session 4 with Dr. Tamer, but also biofluid analysis, particularly CSF, and also emerging markers. And this is just an overview, just to show that neurons being affected in Alzheimer's disease, there's two pathological hallmarks: the deposition of amyloid plaques, which is where aducanumab comes in, Aduhelm, as regards clearing the amyloid plaques, but also there's the neurofibrillary tangles, which is more tau pathology. And this led to the National Institute of Aging and Alzheimer's Association definition and proposal for categorizing different biomarkers. A stands for aggregated amyloid beta, T is aggregated tau, and N is neurodegeneration. So, for aggregated amyloid, we can have things like CSF, amyloid, and the more recently blood tests, as well as amyloid PET scanning. For aggregated tau, you have CSF, phosphorylated tau, and more recently plasma-related tau tests, as well as tau on PET scan. And then for the neurodegeneration, or looking at the actual neural injury, you get the structural MRI scans, i.e. atrophy, FDG, that's fluorodeoxyglucose PET scanning, and also CSF total tau imaging. So this is the ATN categorization of biomarkers. So starting with brain imaging, and as I say, I won't show many pictures, but I'll go through the current guidelines on the role of PET dementia, PET CT and dementia. Dr. Tammer will show more pictures later. The European Association of Nuclear Medicine and European Academy of Neurology recommendations for FDG PET includes in the diagnosis of mild cognitive impairment due to suspected Alzheimer's disease, or frontotemporal dementia, or dementia with Lewy body disease, to find out which is, which is which, whether it's Alzheimer's, frontotemporal, or Lewy body disease that's causing the mild cognitive impairment. And also in diagnosing atypical Alzheimer's disease and pseudodementias, and differentiating Alzheimer's from the other types of dementia. So it's where there's clinical doubt. NICE, they're notoriously conservative. So in their 2018 guidelines as regards diagnosis, they mentioned further tests for Alzheimer's disease if the diagnosis is uncertain. So they recommended FDG PET or a perfusion SPECT, or examining CSF for tau or amyloid related markers. And if a diagnosis cannot be made with one of these tests, then try the other one. So if the diagnosis can't be made with CSF, then you do a PET scan, and vice versa. So this is in the NICE guidelines, 2018. As regards the North American guidelines, the indications for amyloid PET, this is specifically for amyloid PET, is in cognitive decline and dementia, include but are not limited to detection of Alzheimer's pathology in cognitively impaired adults, subjects with progressive cognitive decline who demonstrate atypical features, or features that may suggest another process such as frontotemporal dementia. And basically, this will clarify whether Alzheimer's is there or not. A negative amyloid PET is inconsistent with Alzheimer's pathology. So it suggests that it's, this cognitive decline is due to something else. They also went on to say, at the present time, clinical amyloid PET imaging has not been validated for screening asymptomatic subjects with genetic or other risk factors, for example, ApoE, or in subjects without a clinical diagnosis of a progressive cognitive decline or dementia as established by a clinical expert. And it also cannot be used to establish a diagnosis of Alzheimer's or monitor the response to therapy for Alzheimer's disease. So they're very clear on that. So an overview of the use of PET CT in dementia is its use as a problem-solving tool to differentiate Alzheimer's disease from other forms of dementia, and also in diagnosing mild cognitive impairment, whether it's due to Alzheimer's or other cause of dementia. And as I say, Dr. Tammer this afternoon will go into this in more detail. Now, the IDEA study, this is IDEA stands for Imaging Dementia Evidence for Amyloid Scanning. This was a national study that was performed in the United States on about 18,500 Medicare patients with mild cognitive dementia or dementia of uncertain cause. And the IDEA study was had two aims. One is to look at the impact of a scan on the care management plan of these patients and the impact of the scan on major medical outcomes. And what the outcome of this study was that 2/3 of participants had a significant change in their diagnosis and or care management as a result of their PET scan results. So this goes to show the power of getting functional imaging in dementia nowadays. So 2/3, they actually changed their diagnosis or their care plan. And so that led on to the new IDEA study, which is recruiting more patients. And the study was started in 2020. And this is to look at more the early onset and late onset dementias and atypical presentations to see what effect it has. And also looking more at the minorities, which Tawfiq alluded to, 2,000 Blacks and African Americans and 2,000 Hispanic Latino patients. Now, as regards the imaging modalities, the fluorotaucipir, which Dr. Tamer will be speaking about in his talk in more detail, has got an FDA approval for use in detecting tau in brains for dementia patients. Coming on to bifluid analysis, there are two attacks really, two targets. One is the amyloid and the other is tau, which is more in the neurofilaments. And for just an overview, aggregated amyloid beta, which forms amyloid plaques, are formed in the brain from products of the amyloid precursor protein. And secretases cleave the APP into A beta peptides. And in a normal brain, these peptides are cleared into the CSF or transported into blood across the blood-brain barrier. Now, if there's an overproduction or reduction in the clearance of amyloid peptides, then you start to get it being deposited as amyloid plaques. And plaques primarily contain the A beta 142, that is AB42, inside the plaques. And so the plaques acts as a kind of sink for the peptide when it's being overproduced or undercleared. And so one of the early biomarkers was CSF concentrations of A beta 42, or a ratio of A beta 42 to A beta 40, which gave an indication this may be Alzheimer's or something else. And so this amyloid ratio of 42 to 40 has also got FDA approval as a CSF test, Lumipulse. Now, coming on to emerging markers, ideally we should work towards a blood test, because getting a PET scan on all patients with cognitive impairment or CSF looking at these biomarkers is difficult. If we had a blood test, that would be much more readily available. And so what we've noticed in recent years, in the recent research in the last couple of years, is a hyperphosphorylated tau 217. And the research suggests that tau 217 is very specific for Alzheimer's disease when measured in the blood, and is highly accurate in distinguishing Alzheimer's from other neurodegenerative disorders. And similarly, tau 217, it's found in the neurofibrillary tangles, and this is where the two studies from Barthelemy on the left and Palmquist on the right. If we focus on Palmquist's study on the right first, it shows the difference between non-Alzheimer's disease and Alzheimer's disease as regards the plasma p tau 217. So there does seem to be a difference between the Alzheimer's and non-Alzheimer's patients. And the graph on the left is Barthelmy's study, which the pink and the purple and the red are the p tau 217, which again shows a high degree of specificity and sensitivity compared to some of the other hyperphosphorylated tau proteins. So those are the kind of biomarkers we have in detecting early diagnosis. And as I say, we're almost there as regards a blood test, a standardized blood test we could use with either a ratio of amyloid B 42 to 41 or with PT217. Now, as regards current therapies, and this is where we stand at the moment, as regards general therapies for Alzheimer's, we have the cholinesterase inhibitors, donepezil, rivastigmine, galantamine, which work on the cholinesterase pathways, and they've been around for many years, since 2004, I think, was the first one, item, galantamine, and then rivastigmine and donepezil came along in 2010. So they've been around for a long time. Then the glutamate pathway moderators, for example, memantines, have been around since 2003. And then there's a combination of donepezil and memantine for Alzheimer's. Now, these medicines basically enhance the activity of surviving neurons. They have no effect whatsoever on the disease process. So it has no effect on slowing down disease. They're just making the remaining neurons function properly. So this is where things stood until the last couple of years. And if we look at the annual cost for a patient with Alzheimer's, these from US data, it's estimated it's about $10,000 to $34,000 per patient per year. And for the total cost for the US in that case, it's about $355 billion looking after Alzheimer's patients. And it's thought to increase up to 1.5 trillion US dollars by 2050. So this is the burden, the healthcare burden of Alzheimer's disease, without modifying the disease process. So this is where it's very important to get progress towards more effective therapies. And if we look at this graph, if we develop a treatment by 2025, which is almost there now with the trials that we've just mentioned, if we develop a treatment by 2025 that delays the onset of Alzheimer's by just 5 years, then by 2050, we'll have saved 5.7 million people in the US from getting Alzheimer's disease. And that, if you look at the overall cost of care, currently 355 billion, up to 1.1 trillion by 2050. If we equate that by reducing the amount of Alzheimer's in 5.9 million patients by 2050 with a disease-modifying therapy, we could save up to nearly $200 billion. So this is where it's very important to have effective therapies. And this is an overview of the monoclonal antibodies that are used, and Tawfiq went through the details of the aducanumab studies, and I'll also mention briefly the donanemab, which is the other amyloid therapy that's received accelerated approval by the FDA. Then we also have the tau monoclonal antibodies that are online and being currently investigated. So this is where we stood with the eMERGE and ENGAGE trials. I won't go into this in too much detail. Tawfiq's already gone through this. So essentially what we found was eMERGE did show a significant difference in the cognitive decline, whereas the ENGAGE didn't. So I won't dwell too much on that. And he's already shown this slide. And also the fact that, as regards clearing amyloid, this medicine was extremely effective in clearing amyloid from the brain. And he's mentioned the area E, which is edema, and H, which is hemosiderosis. So essentially in June last year, the FDA granted accelerated approval. This has been approved in the UAE by MOHAP in October last year. And in December 2021, the European agency, they denied approval due to lack of evidence of efficacy and safety concerns, mainly about the area E and H. If you look at the overview, how much does it cost? It's estimated to cost about $56,000 per year, which is about 206,000 dirham per patient per year. And yes, it's expensive, but it's not hugely expensive compared to some of the other disease-modifying therapies we have, for example, in MS, or with some of the hepatitis C antivirals, or the oncology drugs. Yeah. And this is where there's an ongoing trial now, the EMBARK study, which will hopefully be completed by October 2023, to try and get more data about aducanumab and where exactly its role is and which patients we should be using this on. And that should hopefully recruit about 1,700 patients. I'll just include the donanemab, which is the other medicine that got an FDA approval in June last year. And again, it's aimed at amyloid. And again, the criteria was they must be tested positive for amyloid on a PET scan, as well as tau on a PET scan. And this is a quick overview. The primary outcome was the Alzheimer's disease rating scale, which is number A. And yes, it did show a significant difference compared to placebo at the end of 76 weeks, but their original endpoint was that it should show a 6-point difference. So if there's a decline of -10, then it should have been about -4 for them to hit the endpoint that they were after. So even though it was significant, it didn't quite hit that deadline, that endpoint that they were after. And it's just an overview again. So it's showing that it does look as if it has an effect, but it didn't quite hit the target it was after. And again, it shows good clearance on amyloid plaque. This medicine, compared to placebo, over 76 weeks, there's a huge amount of clearance of amyloid from the brain. And they used a load of 24.1 centiloids as a level where if it's below an amyloid load of 24.1 is considered to be a negative amyloid scan for the brain, i.e. it's a normal looking brain. And by 76 weeks, about 60% on the donanemab ended up having a negative amyloid scan. So it was highly effective in clearing the brain of amyloid. These are global tau load. There wasn't a significant difference with placebo on tau, so i.e. the neurofilaments and the deposition. And these, what's interesting is the results of the volumetric MRI scans. You can see that there was more atrophy in the donanemab compared to placebo, both as regards the whole brain, bigger CSF volumes due to more atrophy in the brain. And this is because what's happening is when you're clearing the brain of amyloid, is actually shrinking the brain a little bit, because the brain's normally swollen with amyloid. When you take the amyloid out, the brain often looks smaller. And this has been shown on previous anti-amyloid therapy studies. Now, so this is really where we are at the moment. We have 2 FDA-approved anti-amyloid therapies, and we just basically have to watch this space on where we go with this. Now, I didn't want to concentrate purely on disease-modifying therapies. There have been some other advances as well. There's advances in behavioral therapy and insomnia. This is suvorexant or Belsomra, which received an FDA license for use in Alzheimer's disease for insomnia. And more recently, also, there's pimavanserin, which is can be used for dementia-related psychosis, and this got an FDA approval for use in Alzheimer's, Lewy body disease, Parkinson's disease, vascular and frontotemporal dementias. And it's the first FDA-approved drug to be used for psychosis in a dementia population. And what's useful about this drug for the neurologists amongst you is that pimavanserin, all the antipsychotics have an effect on dopamine receptors. So the standard therapy we used for patients with, for example, Parkinson's disease with dementia or Lewy body disease is we use some of the atypical antipsychotics, quetiapine being the common one that we use. And that has no effect on D1 receptors, which is the one that's particularly, if you block that, it particularly causes Parkinsonian features, but it does have some blocking effect on D2 and D3 receptors. Whereas pimavanserin has no effect whatsoever on any dopamine receptors, similar to lurasidone. So they're the 2 agents that might be of use if you have someone with troublesome extrapyramidal features needing an antipsychotic agent. So those are just on the guidelines now. So quetiapine, as I say, is the one that we often use as an atypical, but then pimavanserin and lurasidone, they have no effect on D1, D2, or D3 receptors. And so, we thought that with that result, the FDA would approve its treatment for dementias with psychosis. But it denied its approval, saying that there were not enough people with less common dementia types that were included. But now that you've seen the effects it has on receptors, it's worth considering in patients with psychosis with extrapyramidal features. So these are my references. As I said, I had a quick run through of the various types of treatment, and I didn't concentrate too much on the aducanumab, which was certainly covered by Tawfiq. But I hope that was a good overview on the current strategies in managing Alzheimer's disease in the current day.
Thank you, Dr. Tawfiq. So, Dr. Ajith, thank you to Dr. Tawfiq before. We do have a few questions that have come in for you, Dr. Ajith. So, if you don't mind, I will just put them to you.
Yeah.
Sure. Okay. How do we better screen in the community, as you mentioned? And is this a public health issue that needs more focus?
Yeah, there are in previous NDFs, I've mentioned screening procedures that could be used that are, like the mini cog, for example, and that these can be done in any medical clinic, and they often take about 2 minutes. So this is something that once we start the cognitive disorders clinic in my hospital, we're going to have this kind of screening for all elderly patients using something that the nurses could use as a quick screening tool. And then if there's any suggestion, they refer to our clinic, and then we can start to get going with more sophisticated tests. But there are some screening tests, and if you're whoever's interested, I could maybe send you some of those, or if we can have a link maybe where I can send to everyone concerned some of the quick screens. There are some good quick screening tests available.
Yes, we will send an email out to all attendees, and if you have any data, we can send that out to the email.
But I think last year I did something about screening, and on a previous year as well. So it's very important, and I was sort of preparing the groundwork for this kind of breakthrough. So I'll send the slides as well as the actual screening procedures.
What is your comment on early genetic Alzheimer's disease?
I think, yes, this is something, particularly with the ApoE, for example, where we can do genetic screen quite easily on ApoE, that these are the patients that we should really focus on at an early stage of the disease, because we know that there's a high risk of them developing Alzheimer's disease. And also the genetic forms, there are some genetic forms of Alzheimer's that we can screen for, that if we know that there's a family member with one of the genetic forms, or they've got an ApoE phenotype and genotype, then we ought to be thinking about screening some of these patients, particularly now that we have disease-modifying therapies.
Thank you.
But I think as regards the overall burden of dementia in the UAE, I think we need to try and get all the dementias first, and then once we've got a good cognitive disorders clinic up and running, and the blood tests available and the pathways to get good genetic testing, then we can move on to the more rarer forms of dementia, i.e. the genetic types.
Thank you.
Sorry.
Can you comment on if there's any research happening into repurposing current FDA-approved drugs for Alzheimer's?
What do they mean by repurposing? I mean getting them available in the UAE?
I assume any current medications that are currently available around, repurposing them for use for Alzheimer's. Any research into this?
All the cholinesterase inhibitors and the memantine, they're available in the UAE. The anti-amyloid therapies, aducanumab, etc., they're not currently available, but MOHAP, as I showed, did approve its use. So if we wanted to, we can actually bring this medication in. It's a question of getting the other steps in line, particularly the imaging, which is what I was focusing on with the high-level meeting I mentioned with the insurance company to agree for the imaging. And now they've agreed to it. That's basically set up all the steps that we need to try and give these disease-modifying therapies. Once we get the PET scans up and running and the appropriate ligands to detect amyloid and tau, then we can give these medicines.
What about stem cell therapy for Alzheimer's?
Yeah, we've just missed out on Rukia. I'm not aware of that being effective at this stage, because I think the pathology is there, and getting the stem cells won't necessarily change the pathology. For example, if you got a particular ApoE genotype, I don't think the stem cells will necessarily protect you from getting the Alzheimer's disease. So I'm not aware of any use of stem cells in Alzheimer's. I think it's being targeted more at amyloid and tau monoclonal antibodies.
And I believe this will be the final question. Do we have any medication at present that stops the progression of AD?
Yes, the only disease-modifying therapies we have that are FDA approved are the aducanumab and the one I presented on. Those are FDA approved. Aducanumab has been approved by MOHAP, so it should be available. We should be able to get it into this country. So the answer is those are the two medicines that are currently available. But as we alluded to in Tawfiq's presentation, it's slightly controversial about the cognitive effects. One study, the eMERGE, showed something and the ENGAGE didn't. So that's where the controversy exists. Certainly, we know these medicines can clear amyloid out of the brain, but the endpoint that we're all after is it improves cognitive performance. And the studies suggest a trend towards improvement in cognitive performance, but they're not quite hitting the endpoints that the trials originally wanted. So I think it's just a question of waiting for more results, particularly the EMBARK study and the ongoing trials with the other agents as well.
I think actually just mentioning Dr. Tawfik's talk, there were one or two questions that came in after he departed, and maybe you could comment on them. As can the patient take it in combination with other medications?
Yes, there's no reason why anti-amyloid therapy can't be used, for example, with donepezil or a cholinesterase inhibitor. There's no interaction between the two. The anti-amyloid therapy is clearing the brain of this amyloid, whereas the other therapy is working on surviving neurons anyway, so that it's not going to have an interaction particularly. So I think the answer is yes, they can be used together, but hopefully with the use of effective disease-modifying therapies, we won't necessarily need to use the older treatments.
I think you may have covered this as well, but is it available now, and what is the cost? I think you did cover it.
Yeah. As I say, MOHAP agreed in October last year to give a license. That's the Ministry of Health and Prevention. They get granted a license for aducanumab, so it can potentially be brought in to this country. At the moment, I don't think anyone's done that yet, but I will be prepared to do that once we get some further data and once we get the PET scans up and running in this emirate. And this is where Dr. Tamo this afternoon in the last talk can bring us up to date on where we are with getting the amyloid and the tau PET scans into Abu Dhabi. We're nearly there.
I think there's one final question that's just came in. It's from a primary healthcare doctor. They say they see lots of patients young patients complaining of amnesia. What do you advise? Should they refer to a neurologist for further investigation?
Yeah, absolutely. I see a lot of patients with amnesia, and a lot of young patients as well, where we tend to find that a 25-year-old with amnesia is related to other factors like being stressed or having a lot of work to do. But I think any patient with any cognitive impairment should be referred to a neurologist so we can just check things out.
Okay. Thank you very much, Dr. Ajith. I think we can conclude this session.
Great, thank you. So I think we have another 15-minute break, and then we resume at. Actually, we're a bit early.
Yeah, 3:30, so, I believe. We'll resume at 3:30.
Yeah, we'll see if we can speak to Jayesh and.
He's online. Dr. Jayesh is already online. So.
Okay, good. So we'll aim for 3:30. So I hope everyone stays on for the last session. It's going to be very interesting for anatomic and functional imaging. So we talked a little bit as a teaser about imaging. So they will cover this in more detail this afternoon. Thank you.
And just on that note, there was Dr. Tawfik Al-Saadi's Biogen Symposium. There's a very, very short survey that we will post a QR code now during the break. If you can just scan that, it will take you 30 seconds to fill out, and Biogen would greatly appreciate all healthcare professionals' feedback on that quick survey. So if you can
I think it'd be very helpful if you could do this survey, because it'll give them a feedback on the symposium. So if everyone could try and do this, and literally takes a few minutes. Yes,
exactly. Yeah. Thank you very much.
Yeah.
We will reconvene at 3:30 with Dr. Jayesh. Thank you.
Yeah. welcome back everyone to the final session in the NDF, and this session will be in advances in neuroimaging. Now, just at the end of the last session, there's a question about screening, and I mentioned something called the mini cog, and Gerard is just sharing his screen with you. This is the mini cog test, and basically, if you go down a little bit, the first step in this screening is you give them 3 words. For example, in version 1, you can use banana, sunrise, and chair, and ask the patient to remember those 3 words. Then step 2 is the clock drawing test, where you ask them to draw a clock, then put all the numbers inside as they go, and then set the hands to 10 minutes past 11. And then, and you can, if you go down right to the bottom, you can use this clock drawing face here, okay? And then go back up. And the third part of this screening is then you ask for the 3 words recall. So that's basically the test. And depending on how you did with the number of points you get for the word recall, clock draw, then you can say that there's a problem with cognition. A cutoff point is less than 3. It suggests that there may be a problem here. So this is a very simple screening tool that nurses in a clinic can do, and it doesn't take very long. And this is a quick way of screening. If there's any abnormality, then the patient can be referred on for further testing. So this is a PDF that we can share with you at the end of the study, at the end of this talk. Okay, so we'll get going with our final session. Our first speaker, is my great pleasure to introduce my current colleague at BMC, Dr. Jayesh Rajendra. He's a fellow of the Royal College of Radiology, and he's working at BMC. He started his career in the oncology department of a leading multi-specialty tertiary hospital in southern India. And then he's acquired additional training and experience in oncology imaging from Singapore, and also additional training in renal and liver transplant imaging during his work experience in Chennai in India. He has a vast degree of knowledge and skills in neuroimaging and also reporting in oncology. So it's my pleasure to introduce Dr. Jayesh, who will be talking about anatomical imaging.
Thank you, Dr. Ajith. Hi, good afternoon. So today I'll be discussing about the anatomic neuroimaging focused on the neurodegenerative disease. And here I'll be covering the topics under what are the different types of imaging modalities that has been used and their uses, and the various MRI imaging sequences, and normal anatomic structures in different MRI sequences, and atrophy scales, for example, this cortical atrophy scale and medial temporal atrophy scales and Fazikas scales, and imaging appearances in different neurodegenerative disorders. See, there are 2 main common imaging modalities that has been used, is the CAT scan and MRI scan. What are the advantages of CAT scan? CAT scan uses X-ray beam, where it passes through the patient's body and reaches a detector. With the help of the computer algorithm, we are able to see the different images. The main advantages of the CT scan is it's easily available, and it has been used in emergency conditions to rule out hemorrhage or stroke. And it is also useful in evaluation of cortical bones, especially at the petrous bones or the posterior fossa, and also used mainly when MRI is contraindicated, especially if the patient is having a cardiac pacemaker or patient is claustrophobic. MRI is used mainly for the good soft tissue differentiation, as well as multiplanar reconstructions, as well as better anatomical details than the CT scan. With the help of recent developments in the multi-detector technology, CT scan, we can use CT scan on 3 planes. We can reconstruct in the coronal as well as sagittal. This is the CT scan at the level of the frontal horn, where we can see how the soft tissue differentiation, the gray matter appears slightly bright compared to the white matter here. The bones or the calcification, it appears like white. The air which is in the frontal sinus, it appears black. In the soft tissues or the brain parenchyma appears grayish color, and the CSF appears is slightly brighter than the black. When we come to the MRI, there is no specific protocol what we use, but basically we should have a good quality 3-plane images, including sagittal, coronal, and axial. Based on the various parameters which we use, time of excitation and time of relaxation, we get to T1 weighted images, T2 weighted images, fluid attenuated inversion recovery, diffusion weighted imaging, and susceptibility weighted imaging. On T1 weighted imaging, we use it mainly for the better anatomical details, and we always we acquire in volumetric acquisition and reformat into 3 planes, either sagittal or coronal, and it is mainly used for assessing the volume loss. And how will you identify whether it is T1 weighted imaging? In T1 weighted imaging, the CSF appears black, and the gray matter appears gray, and the white matter appears bright. And we should also remember there are certain structures which will appear bright. For example, in this image where we can see a normal posterior pituitary, which is always appearing bright compared to the anterior pituitary. There are certain normal anatomical structures like fat. Subcutaneous fat appears bright on T1. In this image where we can see there is a bright structure sitting above the corpus callosum. So this is a case of a corpus callosal lipoma. So the lipoma or the fat appears bright in T1 weighted images. And melanin normally appears bright. For example, this is a case of melanin metastasis where we can see multiple these bright structures which is seen in the brain parenchyma. It is melanin metastasis. So usually the cyst appears dark in color, but certain cysts, for example, in this case, if it is containing mucinous contents, this is cystic structure sitting located anterior to the third ventricle with bright signal change. This is a colloid cyst containing thick mucinous contents. That is why it reflects bright signal on T1 weighted images. This image where we can see this bright structure which is seen in the posterior hemispheric fissure as well as in the sinus. So this is a thrombus. Thrombus in acute thrombus will appear bright on T1 weighted images. And this image, what we can see there is a bright lesion kind of structure seen in the right frontal lobe. This is a case of a subacute hemorrhage. Along with these different structures, we should remember gadolinium contrast will appear bright on T1 weighted images. On T2 weighted images, its main role is to evaluate the pathological details. It is more fluid sensitive sequence. So the fluid structures will appear bright. For example, the CSF and the cisterns will appear bright here. And the white matter appears dark, and it is better for evaluating the thalamic and posterior fossa lesions. In CT scan, where there will be beam hardening artifacts, which will obscure the visualization of the brainstem as well as the cerebellum structures. Flare sequence, which is also called as fluid attenuated inversion recovery. It is similar to T2 weighted images, but the fluid signal is suppressed. So it will have all the signal features exactly like the T2, but the fluid will be black. It is better for evaluation of lesions which is close to the ventricles and sulcal spaces. That is why it is mainly used for any demyelinating diseases, especially for multiple sclerosis, where we can see the caloceptal lesions. White matter lesions, for example, small vessel ischemia, where we see multiple bright structures which is seen in the white matter. In this slide, where we can see there are 4 images taken at the same level, where we can see this is the CT scan, how we can differentiate how the soft tissue or the gray-white matter differentiation is less when compared to the T1, T2, and the flare sequences. If we compare between T1 and T2 weighted images, where the fluid is dark, gray matter is gray and white matter is white, whereas in the T2 weighted images, it is the opposite, where the CSF in the ventricles appears bright, gray matter appears bright, and white matter appears dark. This images, it is the flare sequences. It is same like T2 weighted images, but the fluid is dark. Then we use a sequence called the diffusion weighted imaging. This is based on the water molecule diffusive nature. It should be used in young patients or in rapidly progressive neurodegenerative disorders to rule out vascular cause, especially to rule out any infarct, acute infarct, where in this case, where we can see there is hyperintense signal which is seen in the left parietal region. It is a case of acute infarct. Then we also do a susceptibility weighted imaging. This is based on the susceptibility of the blood products, where it will give a black signal. So in this sequence, what we do is all the blood products will give a high point and signal, which is useful in differentiating the microhemorrhages in amyloid angiopathy as well as the hyperextensive encephalopathy. How will we differentiate? In amyloid angiopathy, these kind of multiple hyperintense foci, which will be seen at the peripheral aspect, whereas in the hypertensive encephalopathy, these microhemorrhages will be seen more over the central region, especially in the capsuloganglionic location. Diffusion tensor imaging. This is a newer technique where we can measure the thermal motion of water molecules. What happens is that water molecules in white matter tend to diffuse more easily along the axonal bundles, which is leading to anisotropic diffusion, whereas on the gray matter, it does not have a clear structural alignment, leading to a more isotropic diffusion. This water diffusion property has been used to infer the brain anatomy. For example, in Alzheimer's disease, where there are neuronal loss, which leads to altered water diffusivity in gray matter. Though diffusion tensor imaging is in the topic, it is still in the experimental mode. It is not yet available in the clinical practice. This is also another sequence called the functional MRI. This is also still in the experimental mode, but it is not used in the routine clinical practice. This functional MRI uses based on the principle of blood oxygen level dependent contrast changes. Different magnetic properties of oxygenated and deoxygenated hemoglobin to identify the regional blood flow changes in the brain. When a neural area has been activated, there will be increase in the oxygen consumption. This leads to decrease in the oxyhemoglobin level in the vascular bed and leads to increase in the signal on the activated area within few seconds. How it is applied? In Parkinson's disease, there will be decreased activation in the motor area, which will lead to decreased signal. For example, in Huntington's disease, there will be impaired activation in the caudate nucleus. All these diffusion tensor imaging as well as the functional MRI, it has a lot of potential, but it is still in the experimental phase. We are hoping it will be used in the routine clinical practice in soon. Let us see some anatomical structures. This is the T1 sagittal sequences. It is one of the important sequence, mainly to evaluate the corpus callosum. This midline structures. This is the corpus callosum, and it is also helpful in the evaluation of the midbrain structure, midbrain, pons, and the medulla oblongata. We can see this triangular structure. This is the fourth ventricle. The one posterior to the fourth ventricle is the cerebellum, and anterior to it is the brainstem structures. T2 axial, one of the important sequence where we would evaluate the gyral and sulcal pattern. We can evaluate the atrophy, particularly useful for the frontotemporal lobes, as well as the widening of the sylvian fissures. Posterior fossa structures, especially the brainstem and cerebellum, T2 axial is very useful, especially we can do T2 weighted in 3D sequences. White matter signal hyperintensity, it's better evaluated in the T2 as well as the flare sequences. T2 is also useful in the ventricular size evaluation as well as the basal ganglion thalamic structures. These three images, it is taken at the posterior fossa level, T2 weighted images, where we can see this, the middle image, where we can see this is the inverted U-shaped structure. This is the fourth ventricle. The one anterior to it is the pons, and which is connected to the cerebellum by the cerebellar peduncles here. The more another important structure here is the internal auditory canal, where we will see the 7th and 8th cranial nerve. And this T2 weighted images is also useful in evaluation of the cranial nerves. This black structure, what we see in the middle, this is the basilar artery. And we can also evaluate if this black signal, which is called it as flow white signal, if there is loss of flow white signal, if we see any increased signal within this, then we can it will be like basal artery thrombosis. These images are taken at the supratentorial level, where we can see the left-hand images, where we see at the level of the midbrain, and anterior to it is the mammillary bodies as well as in the optic chiasm here. These are the optic nerve and the optic chiasm. And we can also evaluate the temporal horn, temporal lobe, as well as the occipital lobe here. This middle images, it is at the level of the frontal horn, where we can see a good visualization of the caudate nucleus, lentiform nucleus, as well as the thalami here. The structure, the posterior, the corpus callosum, the posterior aspect of the corpus callosum, which you can see it is a white matter tract, it appears black. Interhemispheric fissure, the dural sinus here, sagittal sinus here, as well as the sylvian fissure. The T2 and flare coronal images are useful in evaluation of the hippocampal choroidal fissure as well as the temporal horn size. We can compare the symmetry of the hippocampus as well as the choroidal fissure and the temporal horn. And we can also evaluate the mammillary bodies, whether it is atrophied, asymmetric atrophy, as well as any abnormal signal change. Let us come to the different atrophic scales. GCA is one of commonly used. It's called the Global Cortical Atrophy Scale. This is best assessed on T1 or flare images. Most commonly, it is used on T1 weighted images. Scale 0 is where there is no cortical atrophy, and scale 1 is when there is mild atrophy of the sulcal spaces. There will be mild widening of the sulcal spaces, where we can see in this region here, bilateral. Scale 2 is when there is moderate atrophy. There will be volume loss of the gyrate, as well as more widening of the sulcal spaces. And scale 3 is like end stage atrophy, where there will be significant atrophy, significant volume loss, and knife blade appearance of the sulcal spaces here. MTA is the medial temporal atrophy scale. This is based on the visual rating of the width of the choroidal fissure and the temporal horn and the height of the hippocampus. Score 0 is when there is no atrophy. Score 1 will give only when there is mild widening of the choroidal fissure. And score 2 is widening of the temporal horn. And score 3 is there is the moderate loss of the hippocampus volume with more widening of the temporal horn here. Score 4 is where there is significant loss of the hippocampus volume. And if the patient's age is less than 75 years, score 2 or more is abnormal. If the age is more than 75 years, score 3 or more is abnormal. Fazekas scale for white matter lesions. White matter hyperintensities are frequently observed in elderly and also in small vessel disease. Fazekas scale provides overall picture of white matter lesions. No white matter hyperintensities to scale 0. If there are few scattered white matter signal changes seen in the white matter, it will go as Fazekas score 1. If there are many white matter hyperintensities and they started becoming confluent, like here, we give score 2. Multiple large and confluent white matter hyperintensities in bilateral periventricular white matter, we give score 3. Let us come to some of the conditions where we will look into the imaging appearances. Alzheimer's disease, which is one of the most common cause for the dementias. The role of MRI is in the early detection. The most common features what we see is the atrophy of the medial temporal lobe, where there will be a decrease in the hippocampus as well as the parahippocampal volume. There will be widening of the choroidal fissure and dilatation of the temporal horn. Here we can use the MTA scale for grading of this temporal lobe atrophy. In these patients, in these images, what we can see, there is the widening of the sylvian fissure with multiple these white matter hyperintensities. This patient is having Alzheimer's disease with the background of the vascular cause or small vessel ischemic changes also. Vascular dementia, it is the second most common next to Alzheimer's disease, where MRI is more sensitive for large territorial as well as small vessel ischemic changes, also in the detection of microhemorrhage. Subcortical and periventricular white matter hyperintensities are most commonly seen. It is mainly seen in the frontal, parietal, and occipital region. And it will also, thalamic lesions also are seen. It can be unilateral or bilateral. In these images where we can see, this is Fazekas score 3, where we see multiple white matter hyperintensities where it becomes more confluent in the periventricular region here. In this image, this T2 weighted images where we see there is bright signal change which is seen in the bilateral thalamus. Same lesion appears as dark on T1 weighted images. This is a case of a thalamic dementia where there is thalamic ischemic changes are seen in this. Cerebral amyloid angiopathy deposition, where there is a deposition of amyloid in vessel wall of the brain, resulting in hemorrhage. This is the susceptibility weighted imaging, where we see these multiple hypointense foci, which is seen scattered, and it is more in the peripheral aspect, which is a case of amyloid angiopathy. As I said before, it can be differentiated from the hypertensive encephalopathy, where the microhemorrhages or bleed is seen more in the central location on the basal ganglionic thalamic locations. Frontotemporal lobe dementia, where it is characterized by the atrophy of the frontal as well as temporal lobe. It is characterized by asymmetrical involvement. Either there will be more involvement of the frontal lobe or temporal lobe, right or left. This is there are two images where we can see this is the T2 weighted images and this is the flare sequence. We can see there is a atrophy of the left temporal lobe where we can see the knife blade type of appearances with a widening of the sulcal spaces. There is widening of the temporal horn here. And compared to the opposite side, the right side, where there is no significant atrophy, there is asymmetrical atrophy of the temporal lobe, where this is a case of a frontotemporal lobe dementia. We see the progressive supranuclear palsy. The most characteristic MRI features is the midbrain atrophy. But it is, we can also evaluate the MR Parkinsonism index. It is calculated by measuring the width of the superior cerebellar peduncle in the coronal sequence and middle cerebellar peduncle in the sagittal sequence. And also we calculate the area of the midbrain as well as the pons in the sagittal sequence. It is calculated by multiplying the pons and the midbrain ratio with the cerebellar peduncle middle and superior cerebellar peduncle width. When the value is more than 13.5, it is an abnormal value. Oba et al. Had described a method called the modified Parkinsonism index, where reduced midbrain to pons ratio, and if the ratio is normal is 0.24, if this is a sagittal sequence, T1 weighted images, where we can see there is the atrophy of the midbrain, and where the outline of the midbrain becomes more concave here, and there is more sharp or thinning of the anterior aspect of the midbrain, which is giving the hummingbird appearance. In normal, we should see the superior aspect of the midbrain to be convex like this. But in this case, where we are seeing it is more concave here, giving a hummingbird sign. It's a case of progressive supranuclear palsy. In this is the flare sequence, axial flare image, where we can see there is a decrease in the anteroposterior distance in the midbrain at the level of the superior colliculi. If the distance is less than 12 millimeter, then we consider this to be an atrophy of the midbrain, and this gives the characteristic features of the Mickey Mouse sign, where this is the Mickey Mouse ear. In multi-system atrophy, which is characterized by varying degrees of cerebral ataxia, autonomic dysfunction, Parkinsonism, and corticospinal dysfunction. Here on MRI, we will see as T2 hyperintensities in pontocerebellar tract. The more characteristic sign is the hot cross bun sign, where it refers to the MRI appearance of the pons, where T2 hyperintensity forms a cross on axial images representing the degenerative changes in the transverse pontocerebellar tract and median pontine raphe nuclei. This is the axial flare sequence, where we can see this. There is atrophy of the pons in the sagittal image, and we can see this hyperintense cross-like appearance. This is that hyperintense signal which is seen on the transverse corticospinal as well as the median pontine raphe nuclei. So this is the classical hot cross bun sign. In the cerebral, in the putamen type, where there will be a reduction in the putamen volume, along with that there will be hypointense rim on T2 weighted images, which is due to the accumulation of ion. Here we can see there is hypointense rim which is seen on bilateral putamen. In Huntington disease, the most characteristic feature of this is the atrophy of the caudate nucleus. This is the caudate nucleus here, where we can see this atrophy bilateral. We can evaluate the frontal horn width and intercaudate distance ratio to detect if there is any caudate nucleus atrophy is there or not. This T2 weighted images, where we can see this red line, where we see this frontal horn width diameter. This yellow line is within intercaudate distance. So if you make a ratio of these two, and the normal is 2.2 to 2.6, if it is less than 2.2, it is an abnormal and more in favor of caudate nucleus atrophy. We can also detect intercaudate distance with inner table width ratio, and if there is increase in the ratio, then Huntington's disease is a most likely. The range is normal ranges between 0.09 to 0.12. Parkinson's disease, it's characterized by resting tremor, rigidity, and hypokinesia. The most characteristic feature is the loss of swallowtail sign. That means on susceptibility weighted imaging, this is a susceptibility weighted imaging, and normally at the level of the substantia nigra, we will see like a swallowtail. When there is a loss of tail and it becomes more confluence, hypointense at the substantia nigra, it is due to the ion deposition. And it is the classical sign called as loss of swallowtail sign, which is seen in the Parkinson's disease. In Creutzfeldt-Jakob disease, it is it's a rare neurodegenerative disease caused by infectious agent prion. It is a rapidly progressive dementia, and diffusion weighted imaging is the most sensitive sequence than T2 weighted or FLAIR sequence. Here, it is mostly involving the cortical surfaces than basal ganglia or in the posterior fossa, where we will see in the increased signal in the affected areas. This is the diffusion weighted imaging where we will see hyperintense signal in the bilateral cerebral cortex. There will be asymmetrical involvement. How will we differentiate this between the infarct? In infarct, there will be low ADC signal, but in CJD, there will be no loss of ADC signal. So in summary, I would like to say that MRI is the most sensitive sequence, and it should have T1 weighted, T2 weighted, FLAIR, diffusion, and susceptibility weighted sequence. And it should have at least a T1 and the FLAIR 3D volumetrical sequence would be there. And medial temporal atrophy is a characteristic feature in the Alzheimer's disease. And white matter hyperintensity is seen in vascular dementia. There will be asymmetric frontotemporal atrophy in frontotemporal lobe dementia. Midbrain atrophy causing the hummingbird sign, which is seen in progressive supranuclear palsy. And Pons atrophy in multisystem atrophy, cerebellum type. And putamen atrophy with ion deposition, which is seen in putamen type. Cardiac nucleus atrophy is characteristic features in Huntington's disease. On diffusion weighted image, hyperintense signal in the cortical areas, which is a features in the Creutzfeldt-Jakob disease. And these are my references. Thank you.
Thank you very much, Jayesh. That's a great run through on the structural imaging. Would you be able to stay on for the final session for the questions and answers so you can both answer together?
Sure, I will.
Okay, thank you. Is Dr. Tamer online?
Yes.
Great. Okay, so it's my pleasure to introduce our final speaker, last but not least, Dr. Tamer Abdelgawad, who's the head of diagnostic imaging at Burjeel Medical City. Tamer was born and trained in Egypt and continued his postgraduate fellowship in the American College of Radiology in Virginia, United States. He's certified by the American College of Radiologists as a PET-CT consultant, and he's also registered in the Physician Registry Credentials in Canada. He's also a member of the Radiological Society of North America and a member of the European Society for Hybrid Molecular and Translational Imaging. And he's got an extensive experience in imaging, particularly functional neuroimaging. So it's a pleasure. I just met Dr. Tamer about 6 odd months ago, and he's just shown me what extensive knowledge he has of functional imaging. So it's my pleasure to introduce Dr. Tamer for our final presentation.
Thank you, Professor, for your kind presentation for me and for your kind invitation. So today I will go through a quick brief regarding the functional neuroimaging. So as you might know, the functional neuroimaging is the visualization of the brain functions. We mean by this mainly to evaluate the cerebral blood flow and to evaluate the glucose metabolism and to evaluate if there is any kind of pathological depositions. So functional neuroimaging is particularly valuable for mapping the brain functions and detecting any disease-related molecular changes. So regarding the applications of the PET and SPECT, the focus will be the investigation, as I mentioned, of the cerebral blood flow and the glucose metabolism, which would be very helpful in dementia, particularly Alzheimer and Parkinsonism and brain tumors. Localization of the brain function may be the main focus of the functional MRI, which is a very pioneer area for research, and it's really helpful in mapping any early disease. So we will be discussing, these are the three main things, or the three main applications that we can use the state-of-the-art machines to be able to utilize the functional neuroimaging, which would be the functional MRI, the PET, and the SPECT. In the functional MRI, it relates the blood oxygen level dependent effect, which is due to a transient or local axis of the oxygenated blood resulting from changes in the regional cerebral blood flow and neuronal activity. And it's showing the changing blood flow in the brain in accordance with the neural activity, which is asked to be done by the patient. And it reflects which brain structures are activated during the performance of the task required. As you might know, we ask the patient to carry out some tasks. So sometimes we make the stimuli in terms of reading certain words, and we give the patient a designed block of words to be read, like in 20 to 30 seconds. And then we use another block of resting or not doing any activity. We repeat this over several minutes, and then we evaluate the areas of the brain, and we go out with a map for the brain to evaluate any areas of deficiency of the blood flow, cerebral blood flow during and post activity. So we go with a map. This is an example of the map, where in this map, for example, we take the visual memory in green and the oral memory in red, and then both types of memories are labeled in yellow. So this is very helpful when we are mapping the function of the brain, because this detects the changes even earlier before any anatomical change. The functional MRI main advantage is that you don't need any contrast. You are not using any kind of ionizing radiation, so it can be repeated for the patient as many times as we can. At the same time, this will make us able to follow up any of these changes on the functional part of the brain. The main disadvantage is that it lacks the part of the receptor legend, and so we are not able to detect any changes related to the activity itself. In addition, it's very sensitive to the head movement. And of course, as any MRI application, it will be contraindicated in patients who are having devices like pacemakers or something like that. This is a state-of-the-art SPECT, which is, again, this is how the machine looks. Of course, there are different vendors and state-of-the-art machines. It's more or less like a CT machine. And this is the simple gamma camera one, where you can see that there are two gamma cameras rotating around the patient, two cameras rotating around the patient for the acquisition. This is the SPECT is referring to a single photon emission computed tomography, and it was first performed in the 1960s, so it's not a new technology. Its main function is to evaluate the blood flow through the brain and detection of the reduced blood flow in the brain. As I mentioned, it's using the gamma emitting radionuclide, and the typical most common used one is the technetium-99, and also it can be used with iodine-123. The half-life of technetium is 6 hours, which is long enough, so it's easy to not to miss anything. And the two most widely used cerebral blood flow traces for the SPECT is the hexamethyl propylenamine oxime and the ethyl cystinate dimer. Again, the gamma cameras are used for the SPECT acquisition, and they are usually 2 or 3 detectors. Currently, also, there are 5 detectors in the new machines, and they are rotating around the patient in a 2D planar images and starting detecting and acquiring the images. And then we have a reconstruction with the new machines in a 3D form. Definitely, the SPECT has less and lower sensitivity than the PET. The main defect is the spatial resolution, where it's about 7 to 10 millimeters, but in the PET it go down to 2 to 3 millimeters. And the important advantage of the SPECT over the PET are the lower cost and more wide availability, because there are places where there is no availability for PET. The main uses in neurology, it will be pre-surgical evaluation of the seizures, the blood-derived areas of the brain after a stroke, and the dementia. As you can see here, this is a diagram where it shows the brain, and this is an Alzheimer case where the SPECT was used. You can see that the areas with low blood flow, as in the temporal lobe, as in the frontal lobe, and the parietal lobe. And definitely when we go through the rest of the images, you will see that the PET is much more better, because it's giving us even anatomical part in addition to the functional part of the evaluation. This is a case of a 73 years old man with frontotemporal dementia, and he has presented with 2 years history of progressive short-term memory loss. And you can see here that there is a significant reduction in the blood flow in the frontal region, and also in the anterior cingulate gyrus. And this is the thing here is that these findings in the MRI was not that prominent. The MRI of the patient was just showing a mild frontal lobe atrophy, and that's how the functional imaging is much important, or it's very important and crucial to detect the disease in its early stages. This is another patient, a 62-year-old patient. He's hypertensive, and he had a history of stroke since 2 years, and he presented with severe memory impairment and also associated with urinary incontinence. You can see here the SPECT images. The 2 upper rows are in the axial view, and the 3rd row is in sagittal, and then the 4th row is in the coronal view. You can see that there is a diffuse hypoperfusion involving almost the entire cortex. You can see here the part of the left temporal, and you can see here also in the bilateral parietal, and you can see again in the temporal. So this was a vascular type of dementia. This is a very nice case. This patient is a 21 years old left-handed man, and he had a history of seizures since he was 8. And the CT findings were normal. The MRI showed a T2 hyperintense signal and slightly decreased size of the right hippocampus. The EEG finding were also showing acute waves in the right frontal and temporal lobes. Here you can see in the upper row here, this is the interictal, and this is the ictal one in the axial views in the SPECT. You can see that there is in the right temporal lobe, in the interictal one, there is a hypoperfusion. Then in the ictal phase, there is a hyperperfusion. The same here appeared also in the coronal views, and these were compatible with the diagnosis. This is one of the PET machines. Again, there are different machines and different vendors and different state-of-the-art machines. The concept itself of the PET was developed in 1970, and the first machine for the PET CT in the States, it was installed in 2001. The underlying principle of the PET and also the SPECT is to image and quantify physiological function of or the molecular target of interest by non-invasive way. and to improve the spatial and temporal distribution of the radiation emitted. As I mentioned, the spatial resolution for the PET goes down to 2 to 3 millimeters in the new scanners now, and now even the scanners are like not only a PET CT, we have even now the PET MRI, and it's really amazing state-of-the-art machines in terms of helping the patient to be diagnosed early. There are many traces that could be used for the PET, but again, when we speak about PET, we are limited by the cyclotrons, and these cyclotrons are like few in any country. Like always, there is few number of cyclotrons, which are the place where the production of the tracer, where the tracer is produced. So you can see some of the tracers, like the carbon, the half-life is only 20 minutes, the nitrogen is only 10 minutes, the oxygen is only 2 minutes. So all these tracers won't be applicable to be used in different places, because once it will be produced from the cyclotron, it needs to be used immediately, so it will not be easily transported. However, the most used tracer is fluorine 18, because the half-life of the fluorine 18 is almost 110 minutes. So this allows us to be transported from the cyclotron to the hospital to be used in the scanners. So that's why the fluorine, as I mentioned, the fluorine is really most or good number of the application are depending on the fluorine due to the longer half-life relatively compared to the oxygen and the carbon. And we can use the PET definitely in many clinical applications. Like most one is used for dementia, to differentiate the Alzheimer from non-Alzheimer type of dementia. It's used also in the Parkinsonism. It's also used definitely in the strokes, and it has application in the oncology. You can see here the early Alzheimer disease. It's characterized by mild to moderate hypometabolism of the temporal and the parietal cortices, and the posterior cingulate gyrus too. There is a distinct asymmetry is often noticed. As the disease progresses, the frontal cortices also will become involved. So in this case, you will see here in the upper row here, the reduction in the uptake, as can be appreciated, as you can see here in the occipital parts, even here. In the bottom here, this is what we call the objective part, where we use a voxel-based statistical analysis, so that the evaluation of the hypometabolism is objectively evaluated through these maps, not through only subjective evaluation. In cases of advanced Alzheimer, as mentioned, there will be a severe hypometabolism in the temporal and parietal cortices, and the frontal cortex will also be involved. And here the picture will be will be coming with other pictures like other pathologies. And here you have a case of advanced, where you find that there is a significant hypometabolism in both temporal lobes. You can also see here the parietal are affected, and we start here to see that in the right frontal lobe is also started to be affected. The role of the FDG PET in dementia with Lewy bodies is this disorder affects similar areas as those affected by the Alzheimer disease. The occipital cortex is also involved here, which would distinguish the dementia with Lewy bodies from the early Alzheimer disease, because as I mentioned, in the late Alzheimer we can see that the occipital is also involved. The mesotemporal lobe is relatively spared in the dementia with Lewy bodies, and a very similar pattern is observed in the Parkinson disease with dementia. Here is a case where you can appreciate in the dementia with Lewy body, you can appreciate the significant reduction in the hypometabolism in the occipital lobes here, and it is maintained in the frontal lobes and the parietal one. Another application is the behavioral variant of the frontotemporal dementia. And in this one, you will find that the bifrontal hypometabolism is usually found. And usually it's also asymmetrical. It has asymmetrical distribution. And at early stages, the frontomesial and the frontopolar involvement is most pronounced, while the parietal cortices can be affected later in the disease, later in the course of the disease. And you can see here this is a typical patient where there is a frontal hypometabolism. You can appreciate also that there is asymmetrical distribution of this hypometabolism. It's more pronounced here in that case in the right side. The F-DOPA is also very helpful in cases where the PET scan highlights the loss of the dopamine storage capacity in the Parkinson's disease. In the scan of a disease-free brain, you can see that this is a normal brain here. You can see the deposits here are still maintained, or the storage are still maintained in the basal ganglia. However, with a normal Posnerman. However, when you go to a patient with Parkinson, like this one here, you find that there is marked dopamine deficiency in the Posnerman. The role of FDG, again, in Parkinson's disease, it's characterized by relative hypermetabolism. The temporoparietal, occipital, and sometimes the frontal hypometabolism can be observed in a significant fraction of Parkinson's disease patients without apparent cognitive impairment. So the cortical hypometabolism can be fairly pronounced, possibly representing a risk factor for a subsequent development of a PDD. You can see here this is a patient with a Parkinson's disease, and here also there is an element of dementia associated with the Parkinson's disease. The FDG PET in progressive supranuclear palsy, also it's a typical finding in the PSP, is bilateral hypometabolism of the mesial and dorsolateral frontal areas, and thalamic and midbrain hypometabolism is usually also present, in line with the overlapping pathologies in the frontotemporal dementia and the PSP. A patient with clinical frontotemporal dementia can show a PSP-like pattern and vice versa. Here you can see, and that's why it's very important here to not only to use the functional imaging, also to use the anatomical, and it's very important to have a baseline studies so as to compare the progression. In the corticobasal degeneration, it's characterized by strongly asymmetrical hypometabolism of the frontoparietal areas, including the sensory motor cortex, and often it's more pronounced in the parietal area and the thalamus. And you can see it here in that patient, and you can see the clear asymmetry between the left side, which is much more affected relatively compared to the right side. And you can see the clear hypometabolism, which are well established in the FDG PET. Again, there is, as I mentioned, a very important role here in the oncology, and here I used also the anatomical images represented by the MRI to show you that life is not easy. Sometimes we have challenging cases where in the low-grade tumors like grade 2, specifically in this case, you can see that there is in the anatomical part of the MRI, there is subtle changes, and the mild edema which is present also is not delineating the real part of the mass. However, the majority you can see here in the PET CT aspect, you can delineate the tumor very clearly, and you can evaluate that the part of the tumor are showing less FDG uptake relatively to the physiological uptake of the rest of the brain. This is also another example for a case of a high-grade astrocytoma, grade 3. Again, if you go to the MRI site, you can see the lesion. To delineate the exact part, the exact affected part, the FDG would be more helpful because it will show you the effective the lesion itself, and it will not be showing uptake in the part of the edema. So this will make better tumor delineation, and this will help also if we are using, same like in our facility, when we are using the intraoperative MRI, we can use both the functional and the anatomical to help the surgeon for accurate delineation of the tumor. This is a case of lymphoma, and you can see the MRI, the extensive edema is not making us able to delineate the size of the tumor. In the PET CT part, you can see the delineation, the clear delineation of the tumor manifested by the increased uptake, and then the edema surrounding vasogenic edema is not showing uptake. That's also another example for recurrent high-grade astrocytoma grade 3. Again, the same concept and the presence of the edema in the MRI and the activity which can be seen here in this recurrent case. The role also of the FDG is very important sometimes, especially in cases of the left temporal lobe epilepsy, especially when there is no anatomical part, or there is no, still the features are not well established in the MRI. Specifically this case, you can see that the lateralization itself, we did here hybrid imaging. You see here the normal right side here in the cortex, and here reduction of the FDG uptake here. When you go again to the temporal, to the MRI part, without being hybrid with the FDG, you will find the brain, the MRI images of the brain is almost normal. Here, when you go and you find that there is relative reduction here in the hypometabolism in the FDG uptake in the left temporal part of the brain with the hybrid images, and this is a very early stage where it establishes the diagnosis early, and this will help definitely the patient to be treated properly. This is my references, and thank you so much for listening.
Thank you, Tamer, and excellent timing as well for the presentation. So we're open to questions. Whilst we're waiting for the questions to come in, the previous session, we were talking about disease-modifying therapies in Alzheimer's disease, particularly with aducanumab and donanemab getting FDA accelerated approvals last year, which brings us on to PET imaging of amyloid and tau. Where exactly are we in this emirate and in the UAE as regards getting access to such imaging?
Unfortunately, there is a commercial part in the States. We are not able to get some of these traces. So we are trying. We tried other pathway. Till now, we are mainly using the FDG. However, we are missing a great opportunity for some of the really traces that we are using in the States. And again, it's exclusively for certain, the vendors themselves are not ready to sell these kind of traces. So we are really working hard in this path so as to introduce the same traces from another part of the world to be introduced inside UAE so that the patients can benefit from these traces. However, we can cover let's say not less than 70% of the clinical application. We can cover it with the FDG, with the presence of the FDG.
Thank you. And as regards the cyclotrons, where are the cyclotrons placed in the UAE?
So literally in UAE, there are 3 cyclotrons. One is located in El Ain, which is in Tawam Molecular Imaging. The second cyclotron, and I believe it's the eldest one, it's in Abu Dhabi in GICC. And there is another one in Dubai, in Monroe. So there is only 3 cyclotrons in the country. So usually we use, because we are using, again, because FDG has a higher a longer half-life. So we usually, for example, we prefer in our facility to use the cyclotron of Dubai, for example, although there is one in Abu Dhabi. So we keep the one in Abu Dhabi, we keep it as a backup because we know that the cyclotron in Dubai is better one. So it's definitely it will have a better outcome. So getting it from Dubai, since the half-life is long enough, so it's practical enough to be used.
So yeah, just from a logistical perspective, if you got someone who needs an FDG PET, for example, how do you manage to get this? Did you plan to have the patient in and waiting, and you get the ligand in from Dubai?
Yeah, so this is really a very good question, because the logistics in this is that what happened that first of all, in the whole country, there is no cyclotrons working on Saturday and on Sunday, which means that there is no any kind of PET scan on Saturday and Sunday. The rest of the plan we do that we plan our patients one day in advance. So cases for Monday, we plan it from Friday. And even if we have emergency case or any case that popped up by Sunday, we have a direct communication with the cyclotron manager. So we tell them that we need to increase the dose. So production usually happen like 5 in the morning every day in the 3 cyclotrons. And then they start distributing. The drivers are going there by 7:30 in the morning, and they start distributing to the different hospitals in the country here in UAE. In UAE, we have 9 PET-CT scanners. So these PET-CT scanners, the main scanners, or 5 scanners of PET-CT, are there in Dubai. So they are distributing to the different hospitals based on the order that was given in advance. The main challenge here that sometimes we got a call, for example, from a clinic asking us at 12 in the noon, and telling us, I have one patient, I need to accommodate this patient today to do a PET-CT. So we usually tell our colleagues, like the cyclotrons are closed. So you won't find a cyclotron open, and we'll give you a dose especially for you. So the lucky thing that we can do it the next day. But when this thing is encountered on a Friday, this is the real challenge, because it's sometimes hard to tell them that we need to do it like on Monday. So we try usually, what I do it on the daily basis, on operational basis, that I usually order extra dose. By ordering extra dose, I can accommodate any VIP, any emergency, anything. So when they are calling me, the dose is available, and we can accommodate the patient.
Thank you. Just a question for Jayesh as regards the anatomical imaging. You mentioned about standard protocols and things. You know, if we refer someone with dementia, are we applying some kind of standard protocol, or volumetric assessments, for example?
Yeah, we have a standard protocol for the department of BMC. What we do is that we always take routine sequences, like we call it as 5 plan sequences, like T1, T2, diffusion, susceptibility weighted imaging. Along with this, we do T1 as well as flare 3D sequences. Unless if there is any other specific things, then we narrow down the protocol accordingly. Otherwise, this is the general protocol which we follow here. And we also use the same protocol for seizures also.
Thank you. The other thing also is just going back to the functional imaging side of things, and we are about to start off a dementia clinic, and I think recently, after our discussion with Daman, they've agreed to fund or pay for
approved
the scanning, PET scanning, particularly for Daman Basic as well. Have we actually tried that? How successful is this? Have we actually put a few patients through to see if this is viable, and they do actually we get reimbursement for these studies?
I believe we didn't, since we get their approval, we didn't have a trial patient, but definitely they will be very compliant, because it's not only the meeting that we did. You remember that they send us official emails for this kind of approval. What I can expect that it might need some kind of, that we communicate with them in case they are reluctant, and then because their definition was a little bit way beyond our definition. They thought that we are speaking about patient with Alzheimer's or dementia, and then with your help, like you corrected for them the definition that we need to pick up a patient with a mild cognitive impairment continuous for 6 months. So we don't want to wait until the patient is a well-established disease. So I believe definitely while we are requesting in the first few cases, we might need to keep communicating with them, but it's I'm very optimistic in this part. The good thing that when we show them the application, they start approving. So for example, before for like more than 2 years, nobody used the MRI spectroscopy CPT code. And then now they are accepting the CPT code. So it's a dedicated study, and we can use it for the brain, we can use it for the pelvis, for the liver. So we used it in now frequently we are using it for the brain, and they are approving. They are not reluctant like before. We are showing them also that we are not like, we really need to help the patient. So sometimes we are using the high B value technique for the MRI, which is amazing, because it's a functional part. We don't have any CPT code for this one, by the way. We are doing it for free, but we are doing it for the help of the patient. So it's I believe there is a change. We are like throwing stones in a very like stagnant lake, but it's doing great job now.
Yeah, I think it's because no one was doing it before, and now at least we've set. I think we got through the biggest hurdle, which was getting the approval on principle, and now it's just a question of trying out the actual process. And as you say, I think for the first few cases, we will need to keep a high-level contact to make sure it gets approved. This was just, I think, in the last month, wasn't it, that we got this email from them to say.
Yes, true.
It's something we were going, now that there's these new agents available, we wanted to start off a specialized cognitive disorders and dementia clinic at BMC, and there wasn't any point doing that unless we had all the steps in process in place, particularly the PET imaging. So now we're almost ready, and I think we'll be advertising soon for a cognitive disorders clinic so we can start seeing patients. And prior to this session, we just sent out how to screen patients. It's a very simple screening procedure that a nurse could do in a clinic, so we can start screening people to get the MCI, the mild cognitive impairment cases early. And let's just see, it is a lot of hard work.
Professor, like the thing that really like makes me very optimistic, like you know that we are having a top VIB patient. Like, so when it comes to a top VIB means that your work will go abroad. So I got one case, like this case was you can say VVIB like patient, and this patient was just coming for a hip pain. So it was one of my colleagues, they told them, okay, you can go for a screening PET-CT. The amazing thing that we were able to pick up malignancy in the pelvic bone and in the muscle. I believe I showed the images, if I'm not wrong, to Dr. Jaish also. It's impressive. I got the call from them, are you sure? So I told them, like, of course, I'm sure this is malignant. I'm putting clearly in the report that it's consistent with malignancy. And even I suggested a kind of amylonic malignant melanoma. So the good thing in this part that we also like, they asked me, because we are putting in our reports, as you know, we are putting a recommendation in our report. So we put them clearly that the recommendation is to take a core biopsy from the right gluteus muscle and from the right iliac bone at these areas, and we send them clear images and this stuff. They went to Cleveland here in Abu Dhabi. Unfortunately, they were not satisfied. They went to one of the most important centers in France, and they called me from there. They were very impressed, like they're very impressed that they never expected that in UAE we have this kind of caliber of an output. So this really builds the I call it building the bridge with the patient and with the referral, both of them, because you know, with VIB they don't have any issue to go on the same day to go to the States, to go to the Paris, to go to any place. But when they find that the outcome that they have in their country is like this, so it makes a big change. It's a marketing tool that is you just do your job, and the people are marketing for you. So I believe the same thing will happen with the dementia clinic. With you are one of the top notch all over the globe to lead this dementia clinic, and I'm sure in a very short period it will be very, very important, because we will pick up cases with early changes. We'll pick up a VIB cases. We will pick up this thing. It will be a very busy clinic. It will be a very huge business. So from all scopes and aspects, it will be really beneficial for the community, and it will be beneficial for the organization, and definitely we will be the tools that help the community and the organization.
Great, thank you. Yes, I think we'll be able to offer our services all around the Emirate, actually, once we get things set up. So I think this is a good time to finish. I'd like to first of all thank the speakers in this session, my current colleagues, Dr. Jayesh and Dr. Tamer from BMC. But then I'd also like to thank all the other speakers that were representing us in sessions 1 to 3. And also the sponsors, which I mentioned at the beginning of the forum. Without their help, this forum wouldn't be as successful. And I'd also personally like to thank Gerard and his team who organized this. They are excellent behind the background, and everything went so smoothly today. So thank you very much, Gerard, as well.
And on behalf of the audience and the speakers and sponsors, thank you for organising another wonderful conference here this year, and hopefully the NDF next year will be in person. But thank you again for your commitment to science and education in this field. And we were sending you, the audience, an email, and you'll see me within 1 week after the event is finished. So thank you to the audience. We had over 400 attendees at one point. We have around maybe 500 to 600 that attended throughout the day. So a very large number. It continues to grow and shows the importance of this conference, not just here, but regionally as well. So thank you again. And that leaves all the comments from my side. So Dr. Ajith, you can have the closing statements and finish the conference.
Yes, thank you, Gerard. And as I say, thanks to all the speakers and the sponsors, and to you, the audience. I realize it's a weekend now, and so thanks for your commitment to this forum. So please send the feedback and to Gerard, and if there's anything further you need from this meeting from any of the speakers, just email Gerard, and then we'll forward on the CME certificates as well. So thank you, everyone. Goodbye.